Welcome everybody. Thanks for coming. I know these turn out to be kind of long days. You kind of get information overload, so I appreciate you guys coming out to learn about some orthopedic reductions and regional blocks. So we're going to go ahead and get started. So here's our objectives today. We want to discuss and describe these regional blocks that can help decrease pain for our patients, and also talk about some of the pitfalls of these blocks, like maybe why they're not working for you, and then review some common reductions. We're going to talk about reductions of the shoulder, the elbow, and of the hands. So local and regional anesthesia, there are different options we can use. They include things like hematoma blocks, intra-articular injections, nerve blocks, and nerve compartment blocks. Just by a show of hands, how many of you guys are doing nerve blocks, nerve compartment blocks in your ERs? Great, that is awesome. I feel like with our ERs being impacted today and you can't get beds and getting a consultation takes so much time organized, it's really important to start doing more of these regional blocks. So we're going to start with a case. 70-year-old guy comes in after falling. He's a ground level fall. You walk by him, you see his right leg is externally rotated and shortened. And here's his x-ray. So you're going to take a look at his x-ray. And you see this, right? So he's got a fracture there of his femoral neck. So what are our options for hip fracture patients, especially the elderly, ground level falls, right? They can tough it out. You can give them lots of narcotics. You can give them a femoral nerve block or a fascia iliaca compartment block. So that's what we're going to talk about today, the femoral nerve block and the fascia iliaca compartment block. All right, so femoral nerve block, they're very easy to perform. They're easier than a central line. I know a lot of times, like we were rolling out this with our own faculty, it just makes you nervous, like, oh, I'm going after their femoral nerve. You can do it landmark-based or ultrasound-guided based. I'm a fan of using ultrasound because you have it so readily available in your emergency departments today. It gives pain control to the whole anterior thigh and the hip and knee joints. So there's a reminder of your anatomy, right? So it's nerve, artery, vein, starting from the outside, working in. We always remember venous penis, right? So the vein is closer to the groin. So try to remember your anatomy from medical school. But the nerve, your target, is most lateral. Here's a cross section of this. So if you can take a look, there's your nerve, that's your target, that's where you're going for. Now there's your fascia lata and your fascia iliaca. So there's two fascial layers you have to get through in order to get the anesthetic to your goal point. So here's what it looks like on ultrasound. So the yellow is your femoral nerve, that's where you're going, that's where you're going to inject your medicine. Right next to it is the artery and then the vein. So you can see on the ultrasound image that nice bright white triangle, that is your target. This is how you would have the patient set up. Right, you're going to do it in a sterile technique. It's going to be the in-plane approach, and you're going to watch your needle the whole entire time because you are going right next to where the artery is. You want to make sure you see where you're injecting. And this you can see is a video. Your needle is going to come in from the left side of the screen. You're going to see you have that nice, beautiful triangle there. That's the nerve. You see the pulsating artery. You see the vein. You see the needle coming in. Once your needle's coming in the in-plane approach, you're going to inject a little anesthetic. 5 mLs, always aspirating, make sure you're not in a vessel first, injecting and you can see it just dissects right there, right next to the nerve. And then you're going to go ahead and insert that anesthetic right around it, and it provides a nice anesthetic analgesic block for the patient for a long duration of time, so you don't need to give them as much narcotics. And there's the nerve, just to illustrate the target. So how good is this, right? So here's a study done in 2013, randomized control, morphine versus femoral nerve blocks, and it was significantly better pain control at 4 hours with a nerve block. No one in the IV opioid group obtained a significant reduction in pain. We've had some of these been done in our own emergency department lately where the elderly patient gets their block and then they're like, I'm signing out AMA, my pain's better, I'm going home. And we're like, wait a second, your hip is broken, you can't walk. So their pain goes away so much they don't even realize that they still have a broken hip. So what are our pitfalls? Why don't they work? When you do it and you say, she said it was going to work great and it doesn't work at all, what am I doing wrong? The biggest thing is you got to penetrate both fascias. So a lot of people talk about feeling this pop. I don't really feel like you feel a pop going through their fascia. You can see it on ultrasound, but you need to go through both fascial planes. If you don't, your anesthetic is sitting above the fascia, then it doesn't go around the nerve at all. So that's the femoral nerve block. So now I'll talk about the fascia iliaca compartment block. That's basically getting the whole compartment, not just the femoral nerve. So it's going to get the femoral nerve, the obturator nerve, and the lateral cutaneous femoral nerve. So it's getting more anesthesia to the whole area. It's easier, and it's not right next to the artery. So if your nervousness is that you're like, oh, I don't want to be next to that artery. If I inject the artery, this is a big problem. This helps take that away. So it's much more lateral. For both these procedures, remember contraindications. So who can't we give it to? Coagulopathic patients. So people who are on, Pradaxa and Eliquis and Coumadin, we don't want to give it to them. Anybody who is on, who has a cellulitis in the area or multi-system trauma. So the biggest thing, if you have a mid-shaft femur or a car accident, this is not the case for you. The idea is you won't be able to diagnose compartment syndrome. You cannot examine them after you've blocked them because they will be totally numb, so they won't know that. So make sure this is on the isolated, just femoral neck, high fractures. All right, so here's your landmarks again. You can do fascial compartment blocks blind also, or you can do them ultrasound guided. I still recommend the ultrasound. So if you take the as-is, the anterior superior iliac spine, and the pubic symphysis, and you break it into thirds, the lateral third is where you're going to inject, and then the medial third is where your artery and your nerve are. So here's a cross-section of that. So you can see you're going to inject right at the red arrow, and you're going to get the anesthetic, which is in yellow, to go and cover all three nerves, the femoral nerve, the lateral femorocutaneous, and the obturator. So same technique, lateral to medial orientation. You're going to have your inline plane approach. You're going to watch your needle the whole entire time. And so you can see here, there's your artery, there's your nerve, and then here's your two fascial planes. There's your fascia lata and your fascia iliaca. So you can see you've got to get below those two planes to go ahead and inject your anesthetic. So here's a nice ultrasound video of this coming in. You can see on the left side of the screen how you can see your needle tip kind of coming into view. And right now you just see a big hunk of muscle. So that's the best thing, is you're not injecting right over the artery or right next to the nerve. So once you get underneath that bright white plane, that's your fascia iliaca plane, you're going to inject your anesthetic. If it's a 70-kilo person, it's probably going to be like 20 mLs of bupivacaine or ropivacaine. Most of the studies use ropivacaine. And you see as you scan over, there's the nerve, there's your triangle nerve, and then there's your artery. So let's see that one more time. So you can see you're quite lateral. You're quite far away from the artery, which you don't want to go into. So the needle comes in plane approach. You're going to inject, I always inject like just a couple mLs, make sure you're in the right spot. You see it kind of hydrodissect where it's pushing down the muscle, and you're just injecting to this potential space. But you go over, you see the artery, and you see the nerve, so you're far away from that artery and nerve. And then give it 20 minutes and come back. They always say 15 minutes and see how the patient's doing, and they should have a totally numb leg. So here's a study on this based 2012. It's actually done in Australia. We love the Aussies. They do it in the pre-hospital setting with paramedics. So we in America, we're worried about litigious things, we're worried about complications. They are having their paramedics do this on scene with a suspicion of fracture with long transport times, and they're just training them with no ultrasound, and they're having good outcomes. It's a very small study, obviously. Only 12 patients got the block, 30 patients with morphine, but they had great pain relief. So it's something to think that in other countries like the UK and Australia, their paramedics are doing this. We should definitely be doing this more in our emergency departments. Next case. So a 30-year-old guy, he reaches up and feels his shoulder pop out. So what are our options for this guy? Do we give him procedural sedation to put it back in? Do we do an intra-articular injection, or do we do no meds at all? So let's talk about intra-articular injection. So here's a picture of that. What are the pros of this, right? You don't need any IV access. You don't need to put him on a monitor. You don't need to consciously sedate him. Shorter length of stays. It doesn't cost the patient as much. A lot of people talk about infecting the joint space. Lots of trials looking at this, and there's not a single case of a joint infection. I'm sure it's happened out there, but how many people write about their mistakes? Not all the time. But really, that's a very, very small potential risk. So contraindication, once again, anticoagulation or any bleeding disorders. So here's a video of this. If it'll play. Oh. Uh-oh, technical difficulties. He's going to work on that. But while he does that, I'm going to talk to you about it. So you would put a needle in right there at 90 degrees. You would aspirate. If you get blood back, it's okay. Remember that hemarthrosis happens when the shoulder dislocates. You would inject, 10 mLs of your either lidocaine or marcaine into the joint. Lidocaine has been studied a little bit to have a little less hurting of the cartilage. It's going to go numb, and then you can go ahead and do your reduction technique. We'll keep going and see if the other videos play. Shoulder reduction techniques, so we're going to go through quite a few of them. There are lots of reduction techniques out there. My goal for you today would be to gain a couple new ones, have some strategies that when you approach the patient, which technique is best for the patient and for you. So here's an example. Oh no, are my videos not playing? What about this one? Uh-oh. So this is the hard thing with technology. Of course, in the speaker ready room, it all played beautifully, and then for you guys, it's not really playing. So this is external rotation. So if you can imagine the patient, you can see he's already in that picture done a block, right? He's got intra-articular injection. And then you're going to have just external rotation. So you're going to very, very, very slowly rotate all the way out. As soon as you come to 90 degrees, you're going to come forward and then come all the way up. How many of you guys use external rotation in your practice? Oh, yeah, we'll take a model. Perfect. Thank you for helping. Since we don't have a video, we'll do a model. Oh, here we go. We got our video working. Yay, even though you've been an amazing model. Thank you. All right, so you can see he's going out 90 degrees. Once he gets out to 90 degrees, he's going to come all the way forward. The thing with this is you don't have a satisfying clunk, right? This kind of just goes in as you wrap the arm around. All right, so he's coming all the way up and he's going to kind of come forward. And so that's external rotation, is getting it all the way to 90 degrees, and then really the Milch technique, getting it forward. So it's kind of combining the two techniques. So we're going to talk about traction, counter traction. This is kind of the end-all, be-all, right? Everybody should do this technique before you call orthopedics, right? You can do it sitting up, or you can do it laying flat. You as a provider are pulling at one end. You have someone holding the patient in the other. You use the sheet. Always be cognizant of where the sheet is on a female, because you can cause some squishing of their breasts, and they're very mad when they wake up that they have a lot of pain, and so you want it also around their neck. So here's a picture of them doing it sitting, or you can do it laying down, but you just want to make sure that you are in the same plane. So if you're doing it sitting up, some usually has to stand on a chair to make sure you're high. Here's a video of this. You can see they're in the same plane. They're pulling. This is a patient who had gotten sedated for methamphetamine excitation, and so we gave her some benzos to knock her out, and then her shoulder was dislocated. So you can see you're in the same plane there. All right, so scapular manipulation. How many of you guys use scapular manipulation in your practice? Oh, great, quite a few of you. I love it. I think it's great. You kind of add it to other techniques. Doing it just by itself is not as sexy, but putting it together really aids in speeding up the dislocations when you do something else. So remember, you're going to move the glenoid relative to the humeral head. You're going to push the spine of the scapula towards the spine of the patient. You can do it sitting or laying down. And I like to add it to the Stimson. So the Stimson is the laying flat technique, right? You lay the guy down, you hang some weights, and so add it to that. So you're hanging their weights, and then you put a little bit of scapular manipulation on it. This is what it looked like. So you'd have one person or some weights pulling, 10 to 15 pounds of traction down, and then you're going to put pressure on the scapula. Here's a video of this. You can see we have the blonde person pulling straight down, 10 to 15 pounds, and you have someone putting pressure on their scapula, and it's going to go right back in. So who can't you do this on? Probably someone who's pregnant or has a big belly or can't lay flat. They have breathing problems, or they're drunk, or about them aspirating. It's not a good idea to put them on their belly. But otherwise, it's a great technique. Cunningham Technique. So this is Mr. Cunningham, or Dr. Cunningham from Australia. They believe in massage. They don't believe on pulling and yanking. And so the massage technique is great. This is one of my favorite techniques, especially if the patient is adducted. So to do this technique, you have their elbow at their side, and they're resting their hand, on your shoulder. And so here's him. He's kneeling next to his patient. It's just resting there, no traction at all. You can do an intra-articular injection in this patient. The Australians recommend no intra-articular injection, no meds at all, and just to do it just massage alone, and it works really well. The hardest thing is, how many of you guys have ever massaged your spouse, right? 5 minutes feels like forever. You're like, ugh, does your shoulder feel better yet? It's like, I gotta go, I gotta do the dishes. But you have to look at the clock, because as you're massaging their shoulder, you feel like, oh, I've been doing this forever, and you look, it's been like 1.5 minutes. So give yourself 5 minutes. Like, look at the clock, and you're like, okay, it's 10:55, and it gets up to 11 o'clock to give this. And this video is only 2 minutes long. I've cut it for you guys to see, but it's very short. A reduction in 2 minutes is very fast. So you're massaging trapezius, deltoid, bicep. Trapezius, deltoid, bicep, having them sit up, put their shoulders back, good posture, sitting in a chair, just resting their arm. It's a great technique. All right, here's the FAIRS, fast, reliable, and safe. It was published out of Greece. So it's an oscillating technique, right? You're oscillating their arm up and down, up and down. When you get to 90 degrees, you're going to go palm up, right? So she oscillating. When we were doing this, she was asleep, but she was kind of knocking her head around. So we have someone come around and hold her head. And in a second, you'll see that we're like, oh, it's relaxing her whole body. So you get to 90 degrees, the palm is up, and then you're going to go all the way up over her head and forward. So this idea is just like the Cunningham, where it's kind of like a massage, relaxation. A lot of orthopedic surgeons like this technique because you can do it on the field or the football field, right? They can do it laying down or sitting up. And this, sadly, our table was in the way, so our poor resident was trying to move this around. But it works really well. You can do it wide awake. They don't have to be sedated, and it comes forward. All right, the Davos technique. How many of you guys have used this one? This is the latest one published in 2016. Oh, I see a few hands. I love it. It's an auto-reduction technique. So it's great. You get to bill for it and do no work at all. So they do all the work themselves. So this is published originally in 1993, and then when it was first described, no one really did anything about it. Then it got republished again in Journal of Emergency Medicine in 2016, and now it's kind of taking traction. So what you do is the ipsilateral knee. You've got to be able to bend their knee all the way up, and you're going to put their hands together, and you're taping their wrists together. And the reason why you're taping it is you don't want them to be contracting their muscles at all. And then you're going to sit on their shoe, and I just sit down and start having a conversation with them. How's it going? So how'd you hurt yourself? I start taking my history. You know, what happened? And then they lean back. And you guys can kind of do it yourself. You sit there. When you lean back, it kind of relaxes all those muscles. So he's sitting on his shoe, and then he's leaning all the way back. And with that leaning back, they're auto-reducing their shoulder. They're taking that muscle, the spasm releases, and it goes right back in. Some people I noticed in our practice don't want to sit on their shoe, so they have like their family member sit on their shoe and then walk away, like go do some charting, order a few things for somebody else, and then come back and say, like, how's it going? So it's very similar to the Stimson where you leave them hanging with 10 to 15 pounds of weight, but instead they're doing their own weight. They're leaning back. I also teach in the wilderness medicine world, and so this is something you could do if you were hiking or all by yourself. You know, you really just have to lodge your foot so that you can use all your body weight to kind of reduce this. So which technique is best? So the thing is, there is no single technique is best. A lot of factors go into it. Patient positioning, the patient cooperation, what kind of dislocation. So my goal for you today was to learn lots of techniques. So if the patient comes in and their arm is out, right, they can't bring it down, it's dislocated, it's out, like what technique can we use? Well, we could use the fares, right, they're already out here. You could use traction, counter traction, or you could hang them. But don't try to do Cunningham or don't try to do external rotation because you can't even get their arm in and it causes them a lot of pain. If they come with their arm in and they're hunched over and it hurts really bad, so think, what do you need adduction for? Oh, I can use the external rotation, I can do the massage. So kind of use what the patient gives you. I feel like the hardest part is getting them into position. So if you come in the room going, I'm using massage today, and then they're not cooperative, they're homeless, they're smelly, they're high on meth, it's like massage is probably not your best aspect. So kind of go in with a bag of tricks and then use whatever the patient kind of presents with you. Let's talk about a hand case. Okay, 20-year-old comes with hand pain after punching a wall, right? We've all had those great boxer's fractures. So here's your x-ray. So you see the metacarpal fracture, dislocation. You say, okay, what are my anesthesia options? What am I going to do for this guy? So we can do procedural sedation, which of course we don't want to do, right? We don't have the time or the resources to do that. You can do a hematoma block or you can do an ulnar nerve block. So your ulnar nerve blocks work really well. So you can see that your ulnar nerve runs right next to your flexor carpi ulnaris. I know all of us have been a long time since med school and you're like, your flexor carpi what? So everybody pull out your hand. I want you to feel that little tiny tendon that is on the pinky side of your wrist. That is your flexor carpi ulnaris. So at your palmar crease there, you will feel that little tendon, and the nerve runs right by that. So this is the sensory distribution of your ulnar nerve. And there are two approaches. Here's the lateral approach. So if you feel that tendon in your hand, you're going to take a small needle, go right under that tendon. You're going to go just right under it and then past it and inject 1 ml, and then you've hit your ulnar nerve. Now there is an artery right there too, so of course always aspirate to make sure you're not in a vessel, but it's really a great technique. Now here's the volar approach. This is the straight down approach. Same thing. You're going to find that flexor carpi ulnaris, that little tiny pinky tendon, and then you're going to go at the palmar crease, and you're going to go just medial to the tendon, so just towards the center and straight down. Inject about 1 ml, aspirate, make sure you're not in the artery, and it will numb up that whole distribution. This is really good for laceration repairs, great for boxer fractures. So you can see a video of this. So you can see this is the volar approach straight down. You don't need much anesthetic. You can do it blind. You don't have to do an ultrasound. There's no fascial planes to worry about. Just aspirate, make sure you're not in the vessel, and inject. Here it is if you want to do ultrasound guided. You can see there's your artery and there's the nerve right next to it. So if you wanted to, you could pull out your ultrasound and you're going to see the video. You go in, watching your needle come in, and then you can direct the needle right next to that nerve, and you're going to inject 1 to 2 mL. It's such a small space, you don't need a ton of anesthetic. You just put it right next to it. A lot of people are worried about if you put your needle into the nerve. It's really, really hard to do that. If you wanted to aim for that nerve and stick it in there, you could, but they would have a lot of pain because you'd be distending the nerve bundle, and so they would kind of yell at you. So it's very hard to do it. Here's a picture of a hematoma block. You guys have probably all done hematoma blocks. This is a great thing to do if it's a very fresh fracture, right? They just punched the guy this morning, and then they come in to see you. But if they come in the next day, it doesn't work so good. So remember, a hematoma block can go right into the fracture fragment, right where the big hematoma is. When you aspirate, you should get blood because you're right there in the hematoma. They're going to inject some lidocaine right there into it. And that kind of numbs up the fracture fragment so you can do the reduction without them having any pain. Now, if they're a day out or 2 days out, I recommend the ulnar nerve block because the hematoma has kind of solidified. It's not so liquidy. You can't really get your anesthetic in there. So here's your reduction, right? They've gotten their nerve block. You're just going to pull nice and gently on the finger and reduce that 5th metacarpal fracture. And it's going to go right back in. So these are great things you can do in your emergency department. If you don't have rooms, you can even do this in the hallway. It provides a lot of anesthesia for the patient's hand and analgesics. They don't have to have a lot of narcotics. And so here's your treatment, right? You're going to put them in ulnar gutter splint. Their digits are always in flexion, so remember that your hand tendons are longer if they're bent and shorter if they're straight. So if you splint them straight, then in 4 weeks when they take that off, they're going to have to go to hand physical therapy. Depending on your patient population, some of them can get into hand PT easy, some can't. So to prevent that, it's better to splint them in flexion. Get your post-reduction films and send them to ortho. So here's a picture of them after you reduced it. Last case, 35-year-old elbow pain after a fall. You see a T-Rex arm, right? The shortened forearm, a prominent olecranon. You're like, oh, I love these cases. They've got a elbow dislocation, right? So there's 2 techniques you can use. One's the direct traction. So if you can see, you're going to pull direct traction on the forearm while bending it and trying to putting that olecranon back into place. So here's a video of that direct traction. You're holding that humerus down and pulling straight up. You almost always have to consciously sedate these elbow dislocations. Just a lot of force. So it's very smooth, direct traction. The next is a leverage technique. So this is more fun. It's kind of like arm wrestling the patient. So you're going to grab their arm. You're going to pull straight up while bending it. And it does the same thing. It kind of pulls that olecranon into place while doing it. How do you know for follow-up what you're going to need to do? Do you put them in a splint or a sling? Remember, after you've reduced it, if there's no instability, you just put them in a sling. But if there's some instability, if the ligaments are involved, then you want to splint them. Here's another direct traction kind of leverage technique. You're going to hold that humerus down and then pull straight up. All right, so our take-home pearls today, I want you to think an intra-articular block with your next shoulder dislocation. Try it before your next one. Elbow dislocation, I want you to try the arm wrestling technique. And for the nerve blocks, fascia, iliaca, compartment blocks, think of them on your next elderly hip fracture. If you have any questions, I'd love to chat with you after.